Thank you for joining us for this AdventHealth virtual seminar. We hope you'll find the material presented helpful and informative.
Thank you for joining me online today to have an intimate conversation on breast health. So to start off, what is breast cancer? Breast cancer is the uncontrolled growth of breast cells. There are changes in our DNA that cause normal cells to become cancerous. DNA mutations can turn on oncogenes and turn off tumor suppressor genes, which normally regulate cell growth. 90% of these are acquired gene mutations, for example, that occur with aging. Only about 5 to 10% are due to an inherited gene mutation, for example, BRCA gene mutations. There are differences between benign breast tumors and malignant breast tumors. Benign breast tumors do not invade the surrounding breast tissue and do not spread beyond the breast. Usually, they do not regrow after they've been removed. However, malignant tumors can have cells that invade the surrounding breast tissue and potentially could spread beyond the breast to the lymph nodes or elsewhere in the body to other organs. The breast is made up of lobules, which produce milk when women are breastfeeding, and ducts, which carry the milk to the nipples and drain through the nipple. We also have lymph nodes that are found under the axilla or underarm and along the sternum, which drain the breast. Breast cancer can really develop in any part of the breast, but most commonly will involve the lobules or the ducts. There are 4 main types of breast cancer: ductal carcinoma in situ, invasive ductal carcinoma, invasive lobular carcinoma, and inflammatory breast cancer. Ductal carcinoma in situ is a non-invasive form of breast cancer. Essentially, it develops in the lining of the ducts, and the cells which grow abnormally within that duct are contained. It's the earliest form of breast cancer that we can identify, and we stage it as stage 0. It represents 1 in 5 new breast cancers and cannot spread outside of the breast to the lymph nodes or other organs. Invasive ductal carcinoma is the most common form of invasive breast cancer that we diagnose. It too arises from the lining of the ducts. However, the ductal cells, or cancerous ductal cells, can erode through the ductal lining and invade the surrounding breast tissue. These abnormal cancerous cells have the potential to spread beyond the breast to the lymph nodes or metastasize to other organs in the body. Invasive lobular carcinoma is similar to ductal carcinoma, but involves the lobules, and again can spread outside the breast to the lymph nodes or other organs. Inflammatory breast cancer is a rare form of breast cancer that does arise in all components of the breast, but presents differently than most breast cancers because there are associated skin and nipple changes. It can sometimes mimic breast infection and go undiagnosed. So it's important to identify inflammatory breast cancer early to make sure that the appropriate treatment is given. This is a slide which shows the development of breast cancer. As you can see, a normal duct is lined by a single layer of cells. The second image shows that there can be an overgrowth or hyperplasia of normally growing cells. When those cells start to become atypical or abnormal, we call that atypical ductal hyperplasia. They then have the potential to transform into cancerous cells and is associated with an increased risk for malignancy. Ductal carcinoma in situ is the overgrowth of the ductal lining cells in an uncontrolled fashion. Those cells have now mutated, they grow and divide until they fill that duct, and eventually will erode outside of the ductal lining and form invasive breast cancer that can spread outside of the breast. 1 in 8 women will be diagnosed with breast cancer in their lifetime, which means that we have an approximate 13% lifetime risk of developing breast cancer among the general population. Approximately 300,000 women will be diagnosed with invasive breast cancer this year, and 40,000 women will die of their disease. This means that every 2 minutes, a woman is diagnosed with breast cancer, and 1 woman will die of their breast cancer every 13 minutes. The average age of diagnosis is 61. Male breast cancer accounts for only 1% of breast cancer cases. There are approximately 2,500 new cases of invasive breast cancer diagnosed among men annually, and 480 men will die from their breast cancer. This is 100 times less common among white males than white females, and 70% less common among black males than black females. And black men and women have a worse prognosis when diagnosed with breast cancer due to racial disparities. The lifetime risk for developing breast cancer among men is 1 in 833. Breast cancer is the most commonly diagnosed cancer among women besides skin. It's the second most common cause of cancer death among U.S. women. However, the good news is that death rates have been decreasing since 1990, secondary to advances in imaging, which have allowed for earlier detection, treatment advances, and increased awareness about early detection and treatment. There are over 3.3 million breast cancer survivors in the U.S., and this is very important to remember, especially for someone going through treatment. There are certain risk factors that we cannot control that increase our risk for developing breast cancer. Being a woman is the greatest risk factor for developing breast cancer. Aging also increases our risk because as we age, our cells have the potential to mutate and become cancerous. A personal history of abnormal cells, multiple biopsies, or even a personal history of breast cancer elevates a person's risk as well. Family history is also very important and can increase our risk for breast cancer. In particular, family history of multiple breast cancers, ovarian cancer, pancreatic, or other cancers may also be associated with genetic mutations that can increase risk for developing breast and other cancers. Race is also associated with increased risk. The white race is at higher risk than others. And reproductive history. So if you undergo menopause late, or if you had an early menstrual cycle, or for example, if you've had pregnancies later in life or no pregnancy at all, you may be at an increased risk for hormonally driven types of breast cancer. Radiation to the chest has also been associated with a significant risk of breast cancer, for example, in patients treated early in life for Hodgkin's disease. Breast density has also been associated with an increased risk for breast cancer. In particular, if you have heterogeneously or extremely dense breasts on your mammogram, which describes the amount of breast tissue seen on that mammogram, you may be at increased risk for developing breast cancer or for breast cancer to go undiagnosed on your mammogram. And so it's important to understand your mammogram reports and whether or not you have heterogeneously or extremely dense breasts, because you may be eligible for additional screening with 3D mammogram, bilateral breast ultrasound, or even MRI. Exposure to DES also increases risk. The good news is there are risk factors that we can control. For example, being overweight may increase your risk for certain types of breast cancer. The fat cells in our body may cause an increase in production of estrogen and progesterone, which can therefore stimulate the breast and increase the risk for hormone-driven breast cancers. It is important to maintain a healthy weight and body mass index for your age. We can do this by exercising and dieting. Our diets should be low in carbohydrates and sugars and high in foods that contain antioxidants. That would be your green leafy vegetables, bright oranges and reds, fruits and vegetables, and eating lean meats and good carbs. We recommend that patients exercise regularly. At a minimum, we should be exercising 30 to 45 minutes of moderate-paced walking daily, at least 4 to 5 times a week, in order to see a benefit and decrease risk in breast cancer. You should eliminate alcohol and tobacco use from your habits. However, if you must have alcohol consumption, we recommend that it's less than 1 drink a week. But abstinence is always best. And hormone replacement therapy also can increase your risk, in particular when we use a combination of estrogen and progesterones. And therefore, if you're considering hormone replacement therapy, it's very important to assess your risk and discuss your risk factors with your medical providers so that a decision can be made as to whether or not hormone replacement is safe for you. Male risk factors are similar to those of women: aging, family history, inherited gene mutations, radiation exposure, estrogen use, alcohol intake, obesity. However, there are also testicular conditions and certain syndromes, for example, Klinefelter syndrome, that may be associated with an increased risk of breast cancer. So it's important to know that if diagnosed with any of these conditions, such as an undescended testes, orchitis, or orchiectomy, removal of one or both testes. There are some families that have multiple cancers in them, and therefore they may be identified as families at increased risk of having a hereditary type of breast cancer, which, as I stated before, is very rare and only makes up approximately 5 to 10% of cancers. Some features that may indicate an increased likelihood of having one of these hereditary breast cancer syndromes, such as BRCA1 or 2 gene mutations, include early onset of breast cancer, ovarian cancer, especially with a family history of breast or ovarian cancer, a family history of breast and ovarian cancer, bilateral breast cancers, Ashkenazi Jewish heritage, and male breast cancers. So it's important to not only know your personal history, but also your family's history of breast and other cancers on both your maternal and your paternal side. What is screening? Screening is used to evaluate an asymptomatic population to detect disease when cure is still possible. This has helped us detect breast cancer at its earliest stages and helped decrease the mortality rate. Breast cancer screening can involve both clinical breast exams and self-breast exams. Screening can be performed by undergoing a clinical breast exam, which is generally performed by your healthcare professional. For patients between the ages of 20 to 40 years, it's recommended that they undergo a clinical breast exam every 1 to 3 years. For those over the age of 40, a clinical breast exam should be performed annually. And for patients considered high risk for developing breast cancer, either due to a personal or family history of breast cancer or genetic mutation, we should be performing clinical breast exams every 6 months. A self-breast exam is essentially self-breast awareness. We recommend that patients are familiar with the appearance and texture of their breasts and that they're performing a self-breast exam at least monthly to evaluate for any changes or areas of concern. It's important to note any changes and bring those to your physician as soon as possible so that additional workup with mammogram, possible ultrasound, or MRI can be performed. Although the self-breast exam has not been shown to reduce the number of deaths alone, it does help your physician identify changes in your breast and hopefully diagnose breast cancer at its earliest stages. What are some of the symptoms that you can look for on a self-breast exam? Well, that might be changes in how the breast or nipple feel, or look, or even drainage from the nipple. For example, you want to be looking at your breasts for symmetry, making sure that they are the same shape and size. It is normal to have some asymmetry where one breast might be larger than the other, but if you notice an increase in size, breast tenderness, nipple tenderness, a lump or pain within the breast, or any changes in the nipple, such as drainage or pulling inward of the nipple, skin changes such as redness, thickening, or dimpling of the skin. Although not all changes mean cancer, it is important to bring any changes to your provider so that you can be evaluated and breast cancer can be ruled out as a cause. Screening mammogram is still the #1 way to detect breast cancer at its earliest stages when cure is still possible and treatments are minimal. We generally recommend that the general population begin breast cancer screening with mammogram at the age of 40. However, there are some populations who require mammogram screening at earlier ages, for example, with a strong family history or inherited genetic mutation that could increase risk for developing breast cancer. Patients may start breast cancer screening as early as age 25 or 10 years younger than the youngest breast cancer in the family. Mammogram screening is dependent on the ability to detect the tumor within the breast tissue. That means that smaller masses may be more difficult to identify, and depending on the breast density, things could be obscured on mammogram alone. Mammogram is therefore less sensitive in younger women because they generally have more dense breast tissue on mammogram. However, digital technology and now 3D or tomosynthesis has improved the quality of mammogram screening, and in particular, 3D mammograms allow the radiologist to reconstruct a 3D image of the breast, which allows them to identify tumors and distortion in the breast tissue at very small sizes that may have gone undetected in the older analog type films. 3D mammograms have also decreased the rate at which women are called back for additional mammogram views or ultrasound, and therefore is the best quality mammogram that we have to offer today. This is a picture of a screening mammogram. Now, there's a difference between screening and diagnostic mammogram. A screening mammogram is essentially 2 views of the breast, a lateral view and something called a CC view. It's giving the radiologist the big picture of the breast and allowing them to identify any changes within the breast tissue and look for any asymmetries between the 2 breasts. As you can see in this image, breast density can vary among women and may change as we age. Younger women tend to have more glandular breast tissue and less fatty tissue, and on mammogram, that translates into a greater breast density. There are essentially 4 categories of breast density. Fatty replaced breasts are the easiest type of mammogram to identify masses within because the majority of the breast tissue seen on mammogram is composed of fatty tissue. Scattered fibroglandular densities means that there is a mixture of fatty and glandular components on the mammogram. However, when a patient has either heterogeneously or extremely dense breast tissue, what that means is a larger volume of the breast tissue seen on mammogram is composed of glandular breast tissue and therefore increases the risk for underlying masses or distortions in the breast tissue to go missed. That's why, with heterogeneously or extremely dense breast tissue, women may be eligible for additional screening with screening ultrasound or possible MRI. So when should MRI be used as part of screening? In general, reserve MRI for high-risk populations or for patients in which findings are unable to be explained by mammogram or ultrasound alone. For the high-risk population, for example, patients who carry a hereditary mutation such as a BRCA gene mutation, families who have a first-degree relative with a BRCA mutation, or for those who have a greater than 20% lifetime risk of developing breast cancer. Patients who underwent chest radiation, for example, for Hodgkin's disease between the ages of 10 and 30, are also considered to be high risk and therefore may benefit from an annual MRI. Those who are considered moderate risk for breast cancer, with a lifetime risk of breast cancer between 15 to 20%, may benefit from annual MRI, or those who have a personal history of breast cancer, ductal carcinoma in situ, lobular carcinoma in situ, or atypical ductal or lobular hyperplasia may also benefit from MRI screening. And again, those patients who have extremely or heterogeneously dense breast tissue may also benefit from incorporating MRI into part of their screening regimen. Sometimes MRI is used for diagnostic purposes. For example, if there's a palpable mass felt on exam but not identified on mammogram or ultrasound, there's discordance between the clinical exam and the imaging findings, we may use MRI to help further evaluate that breast tissue and characterize the palpable area of concern. When there is dense breast tissue on mammogram and there's concern that an underlying mass may go undiagnosed, MRI may be used in the diagnostic setting. Or if a patient presents with a positive lymph node with an unknown primary cause, we would like to look through the breast tissue to be sure that there's not an underlying small or occult breast cancer within the breast tissue. We may use MRI for the purposes as well. I often use MRI as part of my surgical planning. If I've diagnosed with a patient with breast cancer, I may obtain an MRI preoperatively to evaluate the location and extent of the disease in both the affected breast and the contralateral breast so that I can be sure that I'm going to be performing the correct surgery. We also sometimes will pre-treat patients with medications. For example, some patients may be diagnosed with a locally advanced breast cancer and require medical treatment prior to going to surgery. And so sometimes we use MRI to evaluate the response to their treatment prior to proceeding with surgery. Finally, the best prevention is early detection. It's important for you to discuss your personal and family risk for breast cancer with your provider and to understand when you should be undergoing screening and which type of imaging modalities are best for you. And so we do recommend that patients undergo annual breast cancer screening with mammogram. And I highly recommend that those who have dense breast tissue discuss that with their physicians and that everyone consider using 3D mammogram or tomosynthesis to evaluate their breast tissue. We also recommend regular exercise, abstinence from alcohol and tobacco use, maintaining a healthy weight through diet and exercise, and incorporating fruits and vegetables high in antioxidants in your diet. It's important to also have your vitamin D levels checked because there have been studies that have shown that women who have healthy bones also have healthy breasts, and that a vitamin D level should be within the normal range and can help decrease your risk of developing breast cancer. We also recommend that you reduce your exposure to estrogen and try to avoid hormone replacement therapy, in particular combination hormone replacement therapy, unless absolutely needed due to quality of life. Sometimes we prevent breast cancer in the high-risk population, for example, patients who have a genetic mutation that significantly increases their lifetime risk for developing breast cancer, by putting patients on medications such as tamoxifen or Evista and with prophylactic surgeries. It's very important for you to be familiar with your breasts, how they look and feel, and that you talk to your physician about what breast cancer screening regimen you should be undergoing and when you should start screening for breast cancer. And now we're going to answer a few quick questions. If you have any additional questions that you'd like answered, please type them into Facebook and we'll respond to you shortly. It's important to understand that although breast cancer is common, and we all probably have someone in our family who's been touched by breast cancer, most breast cancers are still being diagnosed in the mid to early 60s and are occurring postmenopausally. For someone who's diagnosed at the age of 70, the risk for the rest of the family is increased. When you have a first-degree relative diagnosed with breast cancer, your risk is approximately twofold that of the general population. But we still recommend that you start screening 10 years younger than the youngest breast cancer in the family. So if the patient was diagnosed at age 70, you would be recommended to start screening 10 years younger than that, which you would already be doing because, as I said earlier, you would start breast cancer screening at the age of 40. It's important to let your physician know about any new breast symptoms you may be experiencing, including breast pain. And although breast pain in general is caused by hormonal changes and oftentimes associated with the menstrual cycle, on occasion, breast cancer can cause pain and therefore should always be ruled out. Thank you all for joining me today so that we can help you keep yourselves and your families safe from breast cancer.